where do you think, or what do you think are the kind of key injuries that get missed or kind of misinterpreted, or conditions in this kind of region that relate to this?
Yeah. Well, I'll go for the big hitters really. So in our teenage athletic population, we need to be on our guard, particularly for two things. One is osgood-Schlatters, so I'm sure you're pretty familiar with that. So that's elevation of the growth plate, the front of the tibia, the tibial tuberosity, particularly in kids that are doing a lot of quads dominant sports. We have a similar scenario, which is less common, called Sinding-Larsen-Johansson syndrome, which is basically an inflammation of the growth plate at the distal pole, the end of the patella. So if someone comes in who is actively is growing, often at an aggressive point of growth, so in the boys it's often around 13, 14, and they're pointing very specifically to the end of their patella, you need to be thinking about Sinding-Larsen-Johansson syndrome. So that's our sort of adolescence. At any age, we can get Hoffer's fat pad impingement. So that's pain and swelling normally from the infrapatellar fat pad. So the fat pad that sits just directly underneath the patella tendon, under the patella. Characterized typically by problems with extension, prolonged standing, or people that often have poorly controlled hyperextension. That would be something to be looking at. So we might see that in our elite dancers, for example, gymnasts. And then the other one that's less common, but certainly you need to be on your toes for, particularly with people playing contact sports, is ruptured PCLs. So blow to the front of the knee, ruptures the PCL, the tibia sags back and overloads the patella. So yes, they come in with pain from the patella, but actually the reason they've got pain from the patella is they're overloading it because of the ruptured PCL that has been missed. So anyone that has a blow to the front of the knee as part of the history, don't presume it's the patella. Look, it's easy enough to look from the side. Knee at 90, is the tibia sagging back? Have they actually got a missed PCL?
We recently had Nick Kane on as a bit of a sort of tangent, but I'll bring it back to this. And at the end of his episode, we were talking about kind of when you have a tough case, or when you go to another clinician for maybe a second opinion, something I'm sure you do regularly with this. Without throwing specific clinicians under the bus, is there kind of any low-hanging fruit, or is there anything that classically you see physios miss with this injuries, but maybe before they send an athlete to you?
I don't know about so much miss, but I think there are some common mistakes, I think, in rehab, and that is loading in too much knee flexion that creates high patellar load, so it stirs the patient up. So the concept of doing strength work was correct. How they've done it is incorrect. So that's probably a really common one. And I think also sort of managing, just focusing in on maybe strength, length, foot position, very biomechanical, and perhaps not looking sufficiently at load management, which I think is really important in the athletic population for this group.